Okay, next we have presenting Dr. Nelipovich, who's the director of the Women's Heart Program from Maimonidea Medical Center. And then she'll be followed by Dr. Amanda Bonikowske, who's assistant professor for program director for rehabilitation care at Mayo.
Okay, good afternoon. I hope you can hear me well. I've had some technical issues, but I'm happy to be here. Let's talk about getting back to the office, going back to the doctor. And initially I thought to talk about it only from the physician and provider standpoint of view, but I feel it's good to talk about from a patient point of view as well, because most of physicians become patients, or most providers become patients at some point. So welcome back. It's nice to see faces without masks, even on Zoom. But pandemic has made a big change, especially here it's felt in New York. And since last March, our world here has been turned upside down. For a couple of months, it seemed that the whole world has stopped. And as cardiologists, we became critical care physicians instead. Our cardiac floors turned into ICUs. And it's been very difficult to provide both primary care and also adequate cardiology care to the patients because patients were afraid to come in. So now let's talk about how can we get back to the office and getting back to some sort of normal. With understanding, obviously, that there is no such thing as going back to normal pre-COVID era. There's a lot of anxieties, a lot of inequities, and a lot of barriers to getting proper care to begin with, and pandemic made it all a lot worse. There are some benefits and new things that came out because of the pandemic. One of them is virtual care. We have been providing virtual care probably from the second week since our offices have been closed. Our cardiology offices were closed for about 2 months, and we reopened in mid-May of last year, of 2020, and have not been closed since then. But it's different for different parts of the country because the waves of this pandemic have affected different areas at a different time. Where we are now in New York, a lot of the businesses have reopened. Some of the mask mandates have lifted, and people are less afraid than they were before. But I don't think it will ever come back to the same level as it was in the past. So there was a benefit, there was virtual care. We're able to see patients virtually, adjust medications, give advice, but not everybody reached out. There are some barriers to virtual care. For example, not everybody has a phone that's capable of video, even though it seems smartphones are a lot more people have smartphones these days. A large older population of our patients here in Brooklyn, New York, do not have smartphones or know how to use them. Even registration for virtual care is difficult for them. We have been providing a lot of phone visits, and we're lucky because we're in the metropolitan area. We're able to provide laboratories that come out to the patient's houses to draw labs. But the care itself has been difficult. So a lot of things I find are difficult to do virtually. For example, examine the patient. There are a lot of missed screening opportunities. We're talking about the whole year worth of screening opportunities. Prior speakers mentioned, don't forget your screenings, your mammograms, your cervical cancer screenings, and it's felt the same way for cholesterol screenings and blood pressure screenings as well. A lot of the care has been missed. We don't know how patients take medications if we do not see patients regularly. We have been, as a rule, prescribing and renewing medications as often as we can. There is also a new finding: people present sicker because the symptoms have been missed, or people were afraid to address the symptoms previously. For about 2 months, it seemed like people did not come with the heart attacks to the hospital because the sicker passed, and it was a very, very difficult time treating patients when they're sicker. Obviously, the outcomes are a lot worse. So also, pandemic has affected how people exercise, or the lack of exercise. A lot more sedentary lifestyle has been promoted because people cannot go out and interact normally. Gyms are closed. People cannot go to usual places where they used to exercise. Malls all of a sudden is not a good place to walk. So change in activity levels also affected overall cardiovascular health. There are other inequities which some of the speakers talked about access to care. There are also increased costs of commuting. A lot of people cannot get to places where they used to go because transportation that's available now is not the same as it was a year ago. And I'll talk a little bit about it in the next slide. Another access to care has been a lot more difficult. The appointments and which doctors are working, how offices are working has changed. Not everybody's going back to pre-COVID schedules of scheduling a patient every 15 minutes because guess what? There is not enough room to space out for social distancing these days. So we have to schedule less appointments per day. And it will affect appointment availability and your doctor's availability to give you the proper care. And then the hidden cost is obviously something that's more relevant to women because a lot more women are primary providers of childcare. Childcare costs have skyrocketed, especially here in the metropolitan area, and availability of babysitters or people who you can trust, who are not ill, to provide childcare while you are at doctor's appointments with yourself, with your loved ones, has changed as well. Next slide, please. So there are a lot of different common anxieties that I find that my patients talk about. The commuting to the appointments has been more difficult. The cost of transportation, cost of taxis, a lot more people are not comfortable using public transportation these days. It costs a lot more to go to the appointment. Here in New York, we have something called Access-a-Ride for which some patients qualify. It's been harder to order Access-a-Ride appointments to come to the doctor's appointments because of their availability as well. There is less public transportation because the schedules over the last year have changed. As ridership plummeted, the schedules for the buses and the trains have changed. It has not come back to normal. And that's something that we as doctors and we as patients have to account for when we're planning our trip to the doctor. Ride sharing is something you may think about twice now because of the risk of infection. I find here in New York, since return back to some sort of normalcy, there is a lot more traffic because a lot more people choose to drive. There's higher gas prices, there's higher parking prices because people want to drive and to stay safe. People don't use public transportation. There are other anxieties that come into play, being around people. I mean, after so much time being socially isolation or in a very close circles of your immediate friends and family, finding to go out in public and interact with people may be scary. There is always this thought, is everyone around me vaccinated? Is there someone sick? They will also find here in New York, there's slightly higher crime rates in comparison to the beginning of pandemic. That's something you have to account for depending on the area where you're planning to go. Next slide, please. So as we reopen, how can we get ourselves, our patients to the office? Obviously, first thing and foremost is if you can, get vaccinated. It's very, very important to protect yourself and your loved ones, and vaccines do work. And hopefully, if we reach enough people being vaccinated, we may stop the spread of the virus, even though we cannot account for all the variants. So if you're planning ahead, there is a lot easier access to vaccine than it was 3 to 6 months ago. Get vaccinated. For planning your visit physically, obviously making the appointments, planning to travel and giving enough time to get to the appointment. Because remember, what you used to think was your 20-minute commute may not be the 20-minute commute anymore. Bus schedules, train schedules, transportation schedules have changed. Something that we find very commonly is patients coming in to the office with insurance cards that are no longer valid because they haven't been to a doctor in the last year. So check to make sure your insurance cards, your IDs are valid. Obviously, we want to provide the care, but we also want to make sure that you do not get huge bills afterwards. So check that your insurance card is still active and you still have the same ID. A lot of things on practical level is also referrals. A lot of insurance companies require referrals now that did not require a year ago. There are some new rules for certain insurance companies that require pre-authorizations for testing that wasn't required a year ago. You have to really do some homework to find out and call, for example, your primary care doctor to see that you need a referral to specialists such as cardiology, such as myself. We do have very good office staff that reminds patients about it and checks it ahead of the time, but we cannot account for every single possibility. So something you have to check ahead of time if you can to be more prepared is, is your insurance card working? Is that the right number? Do you need the referral? You can check, and we have this available for our cardiology outpatient offices, is what's our policy, what's our visitation policy, what safety procedures do we have in place. For example, we check temperature twice before a patient comes in the office, with the understanding that not everybody will have a fever if they were ill with COVID. But we have been doing the same screening procedures since we opened last May. And patients get their temperature checked twice, first downstairs before entering the building, and then at the time of registration. Everybody in our offices is required to wear masks, and I think that that's an office policy for most of the offices for our hospital. So anyone who in contact with the patients will wear a mask. I only stopped wearing N95 masks a few weeks ago myself. Before that, I actually wore an N95 mask for all of my patient encounters. So we still wear masks. You have to account for also social distancing. Our offices have marked out spaces for social distancing and knowing how many people can be occupying the same space at the same time to minimize risk of transmission. It's something we have to account for because there's limited space for that. Obviously, our offices have not expanded, and that's the rule for many other doctors' offices. What other things to do? I mean, something for as a physician that I'd like my patients to know about is probably making a wish list of like things to ask and things to bring with you. So what would you want to ask? Well, one of the things that is brought up, when are you due for your screenings? And if you're seeing your primary care doctor, it's also including mammography, colonoscopy, and other screenings. When should you draw your labs? Do you want to do your lab work before you see the doctor? When was the last time you had your cholesterol checked, your thyroid function checked, and your fasting glucose or your A1C checked? Some offices, and we try to accommodate this more now because accounting for the commuting costs and patients' comfort is what other testing can be done on site at the time of the appointment. Obviously, it's not for all insurance policies, but something to think about. The day of the visit, obviously, I would like to see my patients bring their medications, actual bottles, if not the list with them, because medications may have changed. A lot of patients have multiple providers. It's much easier to reconcile medications if you know what the patient's taking or not taking, because if the bottle is full, if the patient's not taking their medication. Write down your symptoms. A lot of the times I find that people sort of tend to space out and get lost during the appointment. So much stress just getting in and registering that they forget what they wanted to talk about. So make a list of things that are bothering you. It may be a short list, but sometimes it's important to mention, if you've been having chest pain in the last few weeks, but you've been ignoring it, if you are out of breath, simple things. So make a list of the symptoms that are bothering you. Make a list of questions you may want to ask your doctor. Appointments tend to go really quickly. It's really helpful if you ask the question so you come prepared. Another thing, because of the fractured care that a lot of our patients have been getting, sometimes through the urgent care, sometimes through the urgent ER visits, bring whatever paperwork they give you at discharge. It's helpful to know what happened. Sometimes there's labs and test results included. And sometimes we don't have to reinvent the wheel because we know if you have anemia or not, we know what your kidney functions like because it has been done. So if you come prepared, the appointment will be a lot easier to go through. Next step is at the office side. So we have very specific things that we sat down and we talked about, in terms of how to make the visit as safe as possible for the patients. There is a very clear policy about how to schedule patients, how many patients can be seen at the same time in the offices, and how patient will be moved through the office in order to minimize contact with another patient. There is unfortunately a longer wait for both appointments and probably in the office, just because we want to make sure that everyone is observing social distancing. Obviously, everyone mentioned this before, we still observe mask requirements. There's hand sanitizer available at every few steps, what it seems like in the offices, proper ventilation, social distancing, and limitation on the visitors. Only recently our hospital policy has changed about the visitation, but it may not be the same for other parts of the country. We allow one visitor to come with the patient, for example, a home attendant or a family member, but we cannot accommodate multiple visitors because of the social distancing that has to be observed. So you have to check that with individual offices. I know a lot of the offices do not let a visitor in with the patient, which makes even arguing, let's say, if you have a family member that helps you take care of your needs, even arguing for the patient's care becomes a little more difficult. Let's say if the patient has a memory impairment or does not understand everything that's going on. So check with your doctor's office if you can bring a friend, or check with the doctor's office if you can bring your family member with you to the appointment, because that may be different. Next slide, please. Obviously, next slide, please. Telemedicine, and I'm hoping that part of telemedicine would stay. I find it very helpful, especially to communicate important results, to schedule a follow-up virtual visit with the patient after I have seen them in the office. Some things like test results can be explained on the phone or on the video conference. It will minimize how often patient has to come to the office. And also some things, unless you need a follow-up physical exam or a blood pressure check, obviously some things can be explained, and it will make for better continuity of care. So I'm hoping that the telemedicine will stay. In terms of the office practices, we are deep cleaning daily at the end of the day. We are disinfecting specific policies with wipe down of all of the surfaces at the time. There is individual air circulators available. There are masks available to the patients, which is very important because sometimes people forget that their mask gets ripped. Most, about 98% of our office staff right now is vaccinated, which will protect both them and the patients we're seeing. Next slide, please. So just in terms of being prepared to see the doctor, and it's something that's important for providers and doctors know as well, we are trying to encourage as much vaccination as possible. We are also keeping track of vaccinations in terms of we're asking our patients, have you been vaccinated? We do have resources and also appointments scheduled and available. So if a patient expresses interest but have not been vaccinated, we're able to help them schedule a vaccination appointment. We are vaccinating just a few floors down from our offices almost daily. A lot of the times it still requires an appointment, but not so much so these days. Checking ahead about the visitation policy, if you can bring someone with you. It's also difficult because, for example, if you're arranging for a babysitter, if you need childcare, that's a lot more difficult. Obviously, we don't want to expose our children to unnecessarily to any infection, although the social distancing and masking policy are still in place. Checking with your insurance carrier about availability and making sure your cards are active. You don't need referrals, you don't need authorizations. Don't forget your ID and your insurance card. We do have masks and we do have gloves available to the patients when they come to visit if they don't have them with them. A lot of the times, for example, in the beginning when we restarted and the wait times were longer, we actually encouraged our patients to wait and would call them when they're ready to come in. So they minimize time. So patients waited outside or waited in their car until about the time of the appointment to minimize the time they're in the office. Next slide, please. Where do you start with going back to the office? Always a good idea if your primary care doctor is available to come in. As a cardiologist, in the last year, I've done a lot more primary care because of just patients coming in and needing primary care more so than even addressing their cardiology needs. But definitely primary care doctor is a good idea to start with. Also, you may need to see a primary care doctor if they need a specific referral to a specialist such as us cardiologists. Ask about your lab work, which is due. Are you due to check your cholesterol? Are you due to check your A1C? What screening tests should you be scheduling that were missed in the last year? We'll have to recognize that each one of us carries our own anxiety and certain burdens, which came because of the pandemic. Other socioeconomic stresses were made worse, and we have to account for certain anxiety of people coming in and being in person and being touched by another, even doctor, another provider, being examined again, sitting in the office with other patients. I tell my patients, look, when you're ready, unless you have any acute symptoms, we'll be happy to see you. So go slow, go at your own pace, but don't forget that you still need medical care. Someone else mentioned resilience. Obviously, we will survive and we'll make it through this. But a lot of the things, it's important that we account for our emotional stresses as well, anxieties that come with this pandemic. And I find it helpful when my patients do tell me what bothers them the most. What are you worried about? Are you worried about exposure? Are you worried more about certain access to care? So if you're able to state your anxiety, it may be easier to address in terms of what can we do to help you ease your transition back to in-person care. I think we'll be done here, and I'll take a question if you have any.
Dr. Nelipovich, we will take questions through the Q&A chat, and we'll go in the interest of time directly into Dr. Bonikowske's presentation, but look out for written responses if we have any. Thank you.
Thank
Dr. Bonikowske.
Hello, and thank you for the opportunity to join the conference today. What I will talk about is kind of an extension of return to care and patient engagement in cardiac rehabilitation. So first, I'll talk about the impact of the pandemic on cardiac rehab and cardiac rehab programs around the nation. Then we'll talk about virtual cardiac rehabilitation and what that looks like, and then some practical strategies to promote physical activity despite what's going on all around us. So first, I'll start with a picture of our exercise center in our cardiac rehabilitation center at Mayo Clinic in Rochester, Minnesota. And it looks very different now. What we have transitioned to from that large exercise center is to 5 exercise pods. And here's a little closer look. Each exercise pod has 2 pieces of aerobic equipment and then an industrial sized air circulator. So as you heard previously, the HVAC systems are definitely an important consideration in this new world that we live in. And we were actually able to do some testing, especially as we talk about safety of getting back to exercise. We did some testing with particle counters in these little exercise pods. And actually, it's the cleanest air we've ever seen. Even when a patient was exercising, the particles were lower than when they started. So when we talk about new normal and new ways, I don't think that these air circulators are going to be going away in our exercise center. We are, however, close to getting rid of, we call them the walls within the pods. So hopefully we're going to get back to more of our normal exercise center. However, I think distancing will stay for quite some time. I should note that these exercise pods were created out of an abundance of caution. Many programs throughout the United States actually went back to in-person cardiac rehab about 2 months after the pandemic started. And the majority of the programs practiced kind of universal precautions, such as social distancing of equipment, patients wearing masks while exercising, rigorous cleaning schedules. And then of course, reduced class sizes, which I will touch a little bit more on how that impacted access to cardiac rehabilitation. So first here, as we know, current cardiac rehab programs can really only serve about a third of the population that are eligible for cardiac rehabilitation participation. So there's been a supply-demand issue prior to the pandemic hitting. And then there's also a significant regional variation. Here in the Midwest, we have quite a few programs, but you don't have to go very far, and there ends up being only one program for millions of people. And along with that, only about 32% are referred prior to discharge from the hospital. And a few strategies that have been linked to patients more likely to attend would be implementing automatic referrals within the hospital. And then also having a liaison within the hospital that goes and discusses cardiac rehab with the patient before they leave. And specific to women, the strength of the physician recommendation for attendance at cardiac rehab is one of the strongest predictors of a female to attend cardiac rehabilitation. And so we know that we still have more work to do around physician education, as well as around awareness that cardiovascular disease still remains the leading cause of death in women. Additionally, there are prolonged wait times for many cardiac rehab programs. Prior to the pandemic, it was about 42 days, but this of course was exacerbated by COVID. I already mentioned reduction in class sizes, the limited access to the number of programs available. And of course, this was all based on safety measures, but this clearly impacted an already low amount of women attending cardiac rehabilitation. Now, we heard already that absolutely virtual visits and telemedicine was implemented shortly after the pandemic hit. And fortunately, CMS did approve reimbursement for virtual cardiac rehabilitation sessions. So many programs across the nation transitioned to home-based or virtual cardiac rehabilitation. We actually shared a YouTube video through AACVPR, the National Cardiac and Pulmonary Rehab Group, essentially explaining to the other programs across the nation how we did our home-based program. And it was a very low-tech program, a telephone-based program, which that's where the majority of the evidence lies for these home-based cardiac rehab programs. But low-tech, and many of the programs found it easy to implement as long as they were given the opportunity to maintain their cardiac rehabilitation staff, which wasn't the case for many departments across the nation. So along with access, then comes utilization. So prior to COVID, again, more than 80% of eligible patients do not participate, and women are 36% less likely to enroll. So as I touched on already, COVID-19 absolutely exacerbated many of the existing gaps in access to cardiac rehab, both among women as well as minority groups. So these barriers listed here are specific to women. And then some additional numbers among about over 300,000 Medicare patients eligible for cardiac rehab, only 19% of women participated. And from there, the rate of participation for non-Hispanic, Black, Hispanic, and Asian women was only 10 to 12%. And on top of that, women are more likely to have depression, or as we already heard, are more likely to be diagnosed with depression after their event, which has been shown to impact both their participation as well as their attendance to cardiac rehab. Now, as we heard already, telehealth did increase by 50% compared to 2019. But of course, there remain barriers to telehealth services. And we see there as well the increase in Medicare beneficiaries receiving telehealth care during the pandemic. Now, again, as patients considered coming back to cardiac rehab centers, safety was obviously a #1 priority for both patients, providers, as well as the staff delivering the care. To date, there's one publication out there from a healthcare organization where they recorded over 16,000 session hours of on-site cardiac rehab without any cases traced back to the center-based cardiac rehab. And this group employed those universal precautions I discussed before, such as rigorous cleaning, patients wearing masks, social distancing of the equipment, and reduced class sizes. So as I alluded to, virtual or home-based cardiac rehab seems like it's going to be a plausible option now and into the future for delivering cardiac rehab care. The literature that we have to date shows similar benefits and comparable outcomes. Most recently, a group out of Australia actually published a synchronous cardiac rehab program, or the results of a synchronous versus center-based cardiac rehab program, where they demonstrated that the virtual program was not inferior to the center-based program. There are definitely considerations, and not everyone is appropriate for a home-based program. Specifically, it's best for patients that are at low to moderate risk. They have an EF above 35%, and they don't have any significant comorbid conditions. Here we're talking about things like frailty and other conditions that might make exercise at home unsafe. One benefit of these home-based programs is that we will probably further individualize the treatment plans for patients, as well as the use of body weight exercises. So when we start to think about really practical movements, types of activities that we do every single day that we maybe don't focus on as much when they come into the center, because we really strive to get that aerobic exercise in, which is very important. And then the strength training might not be nearly as functional, but some of these home-based body weight exercises are even as simple as sit to stand type activities, maybe stair climbing, and other movements that are very functional for activities of daily living that a person performs every single day. So along with these virtual programs, we're going to see some integration of technology that allows us to monitor their progress and even promote patient engagement. To date, things like smartphone apps, different online platforms, physiologic monitoring is already well established, but will likely have a place in these virtual and home-based cardiac rehab programs, along with physical activity monitoring, numerous apps that can allow us to track our dietary behaviors. And then, of course, AI-driven behavioral change techniques that can help to deliver really individualized education, or for those of you that wear any of the other consumer wearables at the time, most of them already employ this AI-driven behavioral change techniques. And you may have heard they're called nudges or different feedback behavior loops, ways to encourage individuals to make a healthy choice or perform a healthy behavior. I will acknowledge at this point that there are absolutely gaps in access to internet, to smartphones, but I think there's a significant amount of hope out there. There are already companies that have designed essentially a watch that a patient wears that is a complete standalone monitoring device. It doesn't require the patient to have their own cell phone, their own data plan, or internet access. So I think incorporating devices like this can really help us to truly start to reach many of these patients that have digital inequality. Overall, a hybrid model of both center-based and virtual or home-based cardiac rehab will likely be the future. As it stands now, the center-based cardiac rehab really is the gold standard, and we still want to recommend that patients attend center-based cardiac rehab whenever possible. But I think the use and the integration of technology and some of these virtual and home-based options will really help to address many of the barriers that women specifically face when it comes to attendance at cardiac rehab, as well as connection, especially one-on-one connection to their healthcare provider. But I think this final bullet here is bigger than just one simple bullet. We need to deliver socially, ethnically, and racially competent programs, and really, as I said before, meet people where they're at and be cognizant of the apprehension and the fears associated with cardiac rehabilitation participation, as well as other care that we're delivering to our patient groups. So there are some advantages and disadvantages of a virtual program. I mentioned previously the enrollment delays. So ideally, this could help to reduce both delays as well as expand capacity and access. That group from Australia that I mentioned demonstrated that they were able to access far more patients, as well as provide care at a much lower cost. This would also allow for more flexible scheduling, and transportation barriers were discussed very well previously. And so this could help to eliminate and or reduce transportation barriers, especially if we can reduce the number of times a patient needs to actually attend the center. I think probably one of the biggest benefits here will be the integration of care into a person's home routine. So again, we're meeting them where they're at. I think it'll be a big challenge for staff moving forward, is that you really have to get creative and really understand where the patient is, where they live, and what they have available. And then how can you prescribe the best exercises for them? Because I truly think it's possible to do your exercise literally anywhere. And then, of course, regular tracking of daily parameters, which is very helpful for the individual, but then also for the provider to keep track of progress. There are, of course, disadvantages. Currently, there's a lack of reimbursement. Yes, the rehab sessions are covered at the moment, but we have no guarantee at this time that they will continue to be covered, the video visit, virtual visits. There may be reduced intensity of exercise training, but again, I see this as an opportunity for us to really get creative with our exercise prescription and really focus on the patient's needs for their personal life and what they do on a daily basis. Lower social support. However, I think we could turn this one around as well. As was already mentioned, Women Heart conducts numerous virtual social support groups. And I think that we could really expand this and really hear from patients on how they want to be supported and what we can do to help grow and establish that. There's a potential for less accountability, but again, with regular tracking and the experience we have as well, apps and some of the behavioral AI techniques can really help to get at this. We absolutely need more data, more work needs to be done. But at the moment, it appears that virtual programs will help to really address a lot of the barriers and really allow more patients to engage in cardiac rehab. There are, of course, safety concerns for patients at high risk, which will continue to need to address this. But one thought is that the high-risk patients are better served in a center-based program until we no longer deem them high risk, whereas the low to moderate risk patients could attend a center a few times and then do the majority of their program at home. And then, as I mentioned before, the presence of digital inequality, this needs to be addressed, and this needs to be considered as we continue to incorporate virtual and home-based options into cardiac rehab programs. And now a little less specific to cardiac rehab, here are some practical strategies to prevent physical activity decline, as well as to incorporate physical activity into your regular daily routine. There were absolutely a number of people that were impacted and saw a huge decline in their physical activity behavior, and those were primarily the avid gym goers. But then interestingly, a few studies have found that a number of people actually maintained or even increased their activity, especially sedentary individuals. This data is not specific to individuals with heart disease. But what they found is a lot of people started simply just walking more. However, based on other consumer wearable data, patients are still not quite at the physical activity levels that they were prior to the pandemic. One option for a decline in physical activity was things like replacement behaviors. So some people purchased home equipment that could. There are also a number of virtual fitness platforms. But of course, again, there are still social and demographic factors that will influence access to all of this. But there are plenty of online resources that are free, specific to patients with cardiovascular disease. Cardiac College, which was created from colleagues in Canada, is free to access to anyone and includes entire cardiac rehab education curriculum, as well as advice on exercise and exercise videos. And then YouTube definitely has exercise videos available. One page I was really surprised by and impressed by was the Body Coach, which we actually shared this one with a number of our cardiac rehab patients early on, because he went from just simple regular interval training videos to chair-based workouts, some that he labeled for seniors. So I think there's a significant amount of options available. I understand this still requires internet access, but a number of options that are free that don't require any sort of subscription that patients can access from their home. And other practical strategies that we've shared with everyone around us, but specifically for our cardiac rehab patients, is to interrupt prolonged sitting. So every 20 to 30 minutes, getting up and walking around for 2 minutes. And this can be done right in the comfort of your own home. And I think that goes for all of us, as well, as many people have started working from home and maybe having a more sedentary job. On top of that, taking the stairs, that's not a new recommendation, but that one will still help to increase daily physical activity. If a patient does wear a step counter of some sort, then increasing their daily step count. Here we can recommend goals, whether it's based on where the patient is at in their fitness level. It can be 100 steps a week increase, or something like 1,000 steps per week increase. There's also literature to suggest that moving outside, getting our exercise outside, has both physiologic and psychologic benefits. Of course, we need to consider our built environment and the safety of the environment. But if we can, getting outside, and assuming the weather is appropriate as well, is a great option. And then finally, adding interval training to daily activities, such as walking, your simple walk, whether it's to or from a bus stop, or you're walking the dog, and taking the stairs. So there's literature that supports simple intervals of 30 seconds during your normal walking routine, normally while you're taking the stairs. That'll increase our fitness level faster than just taking that 30-minute walk at the same pace. So in summary of what I've discussed today, I think it's abundantly clear that new cardiac rehab delivery models are needed to address both the access and utilization gaps. Virtual or home-based cardiac rehab seems like a plausible solution at this time. Far more work needs to be done, but it appears we can address a number of barriers with these new delivery models. But of course, reform is needed in both delivery and payment as well. And then strategies to increase cardiac rehabilitation among women. The top three at the time are a strong physician recommendation, increased awareness of cardiac rehab as well as cardiovascular disease in women, and then an automatic referral prior to discharge. And then finally, there are abundant exercise and lifestyle resources available online for free that we can start to share with others to help them maintain a physically active lifestyle. Thank you so much again for the opportunity to participate.